our testing measures are going to let us know what the problems are. So we're going to interpret those testing measures, the outcomes of those testing measures, and that's going to lead to our evaluation. And so our evaluation is actually developing those problem lists. So when you take active range of motion and you quantify that with a goniometer, right? You quantify that and say the person, say you are assessing hip flexion at the range of motion, and they're only able to achieve 0 to 40 degrees of hip extension, a hip flexion past the range of motion, right? So we take that, we take those numbers, so we've done the examination. The actual tested measure is goniometry, right? That's the examination. That falls into examination. Now we take those numbers and we evaluate and we examine those numbers to lead us to an evaluation. So when you see 0 to 40 degrees and you have done the examination, you got 0 to 40 degrees of hip flexion range of motion. I'm trying to break down a patient-client management model to you all to show you how important the examination is, because this is where you find your problems to treat. So now, how do we take that 0 to 40 degrees of active range of motion of hip flexion? How do we translate that to evaluation? What is that going to look like with our evaluation? What type of problem is that going to present with? So now our problem, our evaluation, that's going to translate to limited hip flexion, active range of motion, right? And now that becomes a problem. And that's actually our physical therapy diagnosis as well. You see, because we're not giving a medical diagnosis. So now we got to be very, very meticulous with our examination process. All right. We notate problems. So when we examine, we identify problems, and we actually treat those problems. Those problems tend to be the cause of the pain. All right. The problems typically cause the pain. So therefore, once we discover the problems, we don't chase the pain. We're not chasing the pain. Although we get an assessment of the pain using the pain scale, we have that, we know that, we put it aside, but now we want to identify the problems that are likely causing the patients to have painful movement. And then we treat those problems. Because what happens if you just treat pain? You assess, they come in and say a 9 out of 10 or a 10 out of 10. And you just say, okay, if we're going to try to decrease your pain, what's going to happen?
The root of the pain, yeah, is still there, so there'll be pain again.
There you go. That's it, Jill. So the cause of the pain, the problems causing the pain is still there. They're going to still be in pain. Then they're going to leave you and go to another therapist. And until they get to a therapist that's going to actually find the problem and address the problems, then they will get better. Okay? All right. So I want you all to, I see somebody already has it up. I want you all to go through that. And another thing about examination drives intervention. So if you do a lazy examination, if you don't gather enough information to make a strong clinical impression, if you don't find the problems that could be causing the pain, then your interventions are not going to be good, because everything is driven from the examination, from the assessment. Okay. All right. Go ahead and practice, and Dr. McClure and I'll be walking around, and you all can start with the questions and also using your pain scales as well, if you want to use those pain scales. We don't want to have anything interesting to share, because when we do our examination, we have to know how to use the information that we collect. We also have to know how to transition from one thing to the other. So we let a piece of information direct us to something else, okay? So with information that we may get, it may direct us to a special test, all right? It may direct us to muscle selective tension testing. It may direct us to manual muscle testing. It may direct us to go ahead and assess it, active range of motion, goniometry. It may direct us to whatever functional test we're going to use. The patient subjective report is going to direct us to what type of questionnaire we're going to use. like functional questionnaire that we would use. So you have all these decisions that you have to start making as soon as you start gathering the history from the patient. So anything fascinating so far? Anybody want to come up and share what you have so far from your examination process? Come on, Evan. Come on.
You want me to just come up there? I can say it verbally to everybody.
Oh, you can say it verbally from everybody?
Okay, you can right here. Okay, so my patient is Jessica. We all know Jessica got some shoulder issues, so she was a real live patient. She has been having shoulder pain for 8 years now due to an onset injury from handball, bilateral pain. To make it like a patient, I asked her what causes your shoulder to hurt more. She said when I reach for things, so that makes me know she can't really flex her shoulder. And then she said when she want to sit down in a recliner, it hurts for her to relax her hand on the chair. So it's kind of like internal and external motion. I asked her pain. She said it depends on what function she's doing. And she proceeds to say that it hurts the most when she's trying to reach for something because she does that the most. So she has pain at night. So she has a hard time staying asleep at night due to the pain. She also has been to a physical therapist before, probably like 2 years ago. She said it did help because beforehand she was not able to get the range of motion that she has today. And I asked her what does she want from physical therapy, and she said, I want the pain to go away. And as a physical therapist, it's important to educate your patient and say like, hey, I know your goal is to get rid of the pain completely, but that's not something likely that can happen. So what we're gonna do is to try to strengthen and train your shoulder to the point where it eases the pain. It's not necessarily gonna go away, but we're gonna do everything we can to make it so she won't have any dysfunctions during her everyday routine. That's all.
Okay, so I tried to capture some of the things that you were saying that just jumped out to me. Let me know if I missed anything significant. So she's been having what, bilateral shoulder pain?
Bilateral shoulder pain.
So she's been having bilateral shoulder pain for 8 years. Okay? So now, what does the 8 years inform us about her condition? Chronic. So now, how does this play a role in examination, differential diagnosis, and prognosis? So I'm gonna focus specifically on prognosis. There's a lot of things that play a role in prognosis, but a condition being chronic plays a role in the prognosis as well. And so what I mean by the prognosis in her case is how long will it take for her to achieve improvements? Is that gonna be different if the case is acute, or is it gonna be different as a chronic? So how do you expect a longer recovery or a longer rehab with her condition being chronic? So what are you thinking based off of that?
It really can depend because I'm also looking at it since she's had for this long, she may have adapted to the circumstances that she's been doing. So it may take longer to break that habit that she's been doing. Or because it is chronic, we can also do implement interventions that's more, I guess, progressed than a person than an acute patient maybe.
Okay, all right, I can buy that. So we're looking at maybe a longer rehab time with it being chronic to reverse the condition since it is chronic. There's something that they call reestablishing the acute phase, but I'm not going to go there just yet. So she has problems with reaching overhead, in which reaching overhead increases pain. Now, for me as a physical therapist, when a person or a patient tells me that they have increased pain with movement, For me, is that good or is that bad? Or is it positive or negative for me as a physical therapist?
Positive.
It's positive. Why is that?
Because you can pinpoint, or begin to pinpoint where the problem area is.
Right. That's because the pain is reproduced with movement. So if the pain is reproduced with movement, that lets me know most likely it's a musculoskeletal condition. If the pain is reproduced with movement. What if we cannot reproduce her pain with movement? What are we thinking? It could be something neurological, but in most cases, if we cannot reproduce the pain with movement, it could be something visceral that's referring pain to the area. Or it could be cancer, because she did say increased pain in the PM. But if increased pain at PM at night was combined with a lack of reproducing the symptoms with movement, if we lack reproducing symptoms with movement, then we thinking cancer or something like that, tumor, some type of malignancy. And then we want to refer that patient out. We want to do our due diligence. So this is why the examination process, the history taking, is very important. That's why I want you all to practice history taking. It's essential to listen closely to our patient. So now, all right, so we talked about bilateral shoulder pain, gonna sense both sides anyways, 8+ years being chronic, how that's gonna play a role with especially prognosis, all right? Reaching overhead increases pain, that's positive for us, because now we can start doing some things to try to see what is the problem and what's causing her pain. She said pain is dependent on function. When I hear that as a physical therapist, is that positive or negative?
Positive.
That's positive. That's good. That's great. That's what I want to hear. That means that this is something that we could likely treat as a physical therapist. Now, it's disastrous if they come in and they are, I'm not going to say disastrous, but it's a likability that we are not going to be able to help the patient if they're having pain without movement. And if it's at nighttime, and if it's constant. So we are dependent on movement to be cause the pain, right? Now, we talked about this. So now that she has pain in her shoulders, right? And it's chronic. It may be the lack of patient education. We may need to educate this patient on how to sleep. Sleeping with pillows propped up on her arms, sleeping on the back, sleeping with legs elevated, whatever the case may be. Anything but sleeping on the side, right? Because sleeping on the side is going to impinge that supraspinatus muscle in tendon even more. It's going to make it painful. It's not going to let it allow it to rest and recover how it should. And so it's going to be constantly getting some impingement or something going on if this person continues to sleep on the side. So now this allows us to ask more questions. So now we may go increased pain at night. So this is how you use the information. Increased pain at night, right? However, her pain is dependent upon function, and her pain increases with overhead movement. So now with increased pain at night, I'm not thinking malignancy, I'm not thinking cancerous, because now I'm going back to this piece of content. So now I'm thinking about position, sleeping position, posture, activity. So I'm thinking about sleeping position. I'm thinking about posture. I'm thinking about patients' activities that they engage in. So now my questions lead me down another path. All right. The patient has had PT before with positive outcome. Is that good? That's good. I like that. So this is all setting me up. I'm using this information to establish my prognosis. So the prognosis also consists of if you think the person has a potential for good outcomes. So with most of you, you're going to be doing documentation in Web PT or whatever source we use, and there's going to be a box that you check. Where's the person's potential for rehab? You know, and you check good or poor or fair, but you're basing that off all of the information you collect. You putting everything together. You putting your history together, your subjective history, along with objective findings. So right now I'm just on subjective findings, but then you got your objective findings, and you're going to put all of that together to determine your differential diagnosis and also your prognosis. Right here, I want the pain to go away. Okay. So you know the patient wants the pain to go away. Now, what do we have to educate our patient? There you go. That's it, Tia. Say that again, Tia.
I'm not here to treat your pain. I'm here to get to the root. I've probably been saying a lot more professional, more professional way. Anywho, I'm not here to treat your pain. I'm here to treat the root of the problem.
Exactly. So, Miss Jessica Castro. So, Miss Castro, I've notated your pain. I've taken a notice of your pain. And we're going to try to find the problems that are causing your pain. It may be muscle weakness, and it may be joint hypomobility. It may be that your muscles are tight and bogging down and compressing on nerves. I mean, we're going to find out, and we're going to address those problems, and then in turn, we want to see if you're moving better, if you're functioning better. If we can get you moving and functioning better, then what we want to correlate with that is decreased pain. You see, this is how we have to talk to our patients and educate our patients, right? Now, another thing, we hear all this about pain. Another more important information that we have to gather is what type of pain. So we need to be asking our patients, can you describe the pain? Why is this important?
Chart pain, it's different modes of, or like different causes.
Okay. So say you got a patient say, man, so say Miss Castro tells us it's aching and throbbing pain. It just constantly aches and throbs, and it aches more when I move. It throbs more when I move, right? What are we thinking? What are we thinking is the source of the pain?
Vasculature.
Say vasculature.
Yes.
Okay. Anybody else?
Okay.
Muscle.
Okay. Just kidding.
Some say muscular tendon, muscle tendon pathology. Something going on. So muscle tendon or musculoskeletal dysfunction. All right. Now say the person says my pain is sharp. Sharp, shooting, nervous and tingling, right? Burning. Then we're thinking what? Some type of neural entrapment. Or neural involvement. Okay? Some type of neuropathology. So your pain description is very important to let you know what could be going on. Now, what if they say it's just dull? What could it be? Athlete came, say, man, I got tackled on my wrist, and my wrist was like this, and all the football players jumped on the pile, and they just jumped on me. And but now I got up, but my wrist was hurt, but it's a dull pain. It's just dull. Osseous structure, fracture. So it could be some type of osseous structure involved. I think I'm studying this right. Osseous or bone. Okay, so now this person, we have direct access. They came to us, and you've done your examination, you've done your test and measures, and at the end you may say, okay, you may need an X-ray. Okay, so have you been to your primary care? Have you been to the ER? They're like, no, I came to physical therapy first because I was experiencing pain. So now this is what we have to know. Where we will need some imaging. All right. Now, sharp shooting, numbness and tingling, and burning. Does this rule out connective tissue dysfunction? Does this rule out connective tissue dysfunction? I see y'all saying no. Why not? So connective tissue dysfunction talking about muscle tightness. Does this rule out muscle tightness or muscle hyperactivity?
Yeah.
So now, say my hamstrings are taut, and I'm getting numbness and tingling down my heel, the bottom of my foot to my toes, but I got very taut hamstrings. Could that be a problem? Could that be a problem that's causing sharp shooting, numbness, tingling, and burning? Why is that? So that muscle could be bogging down, compressing what nerve? The sciatic nerve. You see? And so now I can still have those neurological symptoms with muscle tautness. You see? So don't neglect that. Same thing in piriformis, right? You've heard of piriformis syndrome? But a person has tight piriformis, but they have what? Neurological symptoms. So what I'm saying is you have to know what to do with the information that you're getting from your patient during the examination process. The examination process is so important that we just talked about right now we just talked about the subjective portion and how to use the information that your patients are giving you. Subjective information. Very, very important. You want to get practice with this. If your family member say, I'm in pain, you be like, let me do an assessment on you. Let me examine you. This is where you get good practice in with your family members. You see? And you try to figure out what is going on. Then you let their subjective information guide you to your test and measures. What are test and measures? Okay, so we say goniometry, manual muscle testing, muscle electric tissue testing, special tests, palpation. Did y'all see palpation in the slide? Palpation is very important because we learn things and find out things through the use of our hands. Okay, so do not neglect palpation for your objective test and measure. What's another one that's hallmark that we start to do as soon as we look at the patient? We're looking at what? We're looking at how they present with posture. Okay, we're looking at how they stand from the chair and walking back to the waiting room. All right, and we're looking at how they walk when they walk to the to the treatment area. If I miss something, we're going to continue to go over this because we're going to build on this. So for each joint complex, we're going to come back and revisit the examination process and objective examination. So you already know you're going to be tasked with performing passive range of motion for the shoulder joint complex. You already know you're going to be tasked with performing muscle selective tension testing. Now, when we get into lab, we're going to be going through lab, and I'm going to be teaching you all how to assess accessory motions, which are component motions and joint play motions. Then we have to go through special tests as well. All right, and so all of those items are going to be you're going to be assessed on the lab practical. All of those items are foundational content for what? There you go. You have to have a command of it. We have to do our job. We have to do our job. So, what questions do you have before we wrap it up? All right, go ahead, Tia. Then I come to you, Evan.
Okay, this is not like I don't know. Anyways, when we talk about the X-ray to refer, would we refer to a physician for them to refer to an X-ray or a radiologist, or would we refer to a radiologist?
Being that we have direct access, we can refer to a radiologist.
Yes. I find it kind of seen where though, like radiologists might not perform the order though from a physical therapist.
If they don't, then in that case you can refer to the physician. So if you live in a state to where they won't accept it from a physical therapist, then you can refer it to a physician. But I'm looking at it from a standpoint, most radiologists are MDs and specializing in radiology. So they are physicians as well with a specialty in radiology, okay? And so in a sense you're referring to MD, but they may want it from the general practitioner. And so if that is the case, then you just send a referral to the primary care physician, and then they'll get it set up for radiology. And when you read the radiology report from the radiologist, what is that radiologist giving you? A clinical impression. When you read the radiology report, it's going to say clinical impression, right? Ebony had a question. Go ahead, Ebony.
So during my clinical rotation, we had 2 patients that came in for vertigo. Have you ever had that in your clinic? And how would you do your examination with them? How to get them?
So, if I have patients come in with vertigo, I'm going to do a musculoskeletal screen because I know that the sternocleidomastoid muscle, if it is taut, it could play a role with vestibular dysfunctions, right? It can make a person seem off balance. So with my skill as a manual therapist and knowing what I know, I'm gonna assess musculoskeletal problems that can contribute to that. Now, if they need more in-depth treatment, I can do it and look up in the books and go look it up and what to do, but I actually refer them out to someone who specializes in vestibular disorders and treating vestibular dysfunction. So in my case, I'm a certified lymphedema therapist. So other therapists who come across patients with lymphedema, I get referred from PTs all the time. They like, Dr. Carter, this is a patient who I think has lymphedema. We send this patient to you. So that's how the PT community works. So patients who come to me, if I get referrals for pelvic floor dysfunction, I send those off. I refer those out, okay, to someone who's a pelvic floor therapist. So as a physical therapist, I don't try to take on everything. I try to treat those problems which I have a lot of experience with, and which is within the scope of my certification in conjunction with my physical therapy license.